Welcome to this session. I'll be taking you through management of sickle cell disease and other haemoglobinopathies in pregnancy, but emphasis will be laid on management of sickle cell disease in pregnancy. I am Dr. Adedeji Nife, a senior registrar in the Department of Obstetrics and Gynecology, Obafemi Awolowo University Teaching Hospitals Complex, Nigeria. At the end of this study, you should be able to understand the epidemiology of sickle cell disease in pregnancy. You should be able to describe the pathophysiology of sickle cell disease. You should be able to know the effect of sickle cell disease on pregnancy and the effect of pregnancy on sickle cell disease. Also, you should be able to understand the management of pregnant women with sickle cell disease, and then be able to highlight the management of sickle cell disease in pregnancy and the interventions that you need to put in place to reduce morbidity and mortality that are associated with sickle cell disease in pregnancy. Sickle cell disease is a chronic hemolytic disorder that is marked by tendency for the hemoglobin molecules within the red blood cells to form polymers and deform the red cells, making it form a sickle or crescent shape. This results in vaso-occlusive crisis as the red cells, the deformed cells, find it difficult to navigate the blood vessels. This leads to accelerated hemolysis and repeated painful crises. Haemoglobinopathies are inherited disorders that result either from synthesis of structurally abnormal hemoglobin chain, as found in sickle cell disorder, or defective synthesis of normal hemoglobin chains as seen in thalassemia. The disorders include sickle cell anemia, in which there is homozygous inheritance of the sickle cell traits, the sickle beta thalassemia syndrome, the hemoglobin SC disease, hemoglobin SD disease, and the hemoglobin SO disease. The epidemiology of sickle cell disease. This disorder is found to be prevalent in Africa, the Mediterranean countries, in India and Middle East area. Other areas where it is found to be very common include African American descent, among the Hispanics of Caribbean origin, and in some parts of South and Central America. Hemoglobin S has been found in areas with high prevalence of malaria. About 5 to 7% global incidence of sickle cell disease is known worldwide. The greatest burden of this disease is found in sub-Saharan Africa and in Asia. The prevalence of sickle cell traits ranges between 10 to 45% in various parts of sub-Saharan Africa. While in Nigeria, sickle cell disease affects about 2 to 3% of the Nigerian population. Sickle cell disease is inherited in an autosomal recessive fashion, either in the homozygous state or the heterozygous state. When inherited in the homozygous state, it is termed sickle cell anemia, and this is associated with a lot of complications in childhood and also in pregnancy. This shows the inheritance of sickle cell traits. This is the carrier of sickle cell traits, which is the man, and this is a woman who carries sickle cell traits. This is a normal hemoglobin. This is a carrier state. This is a child who has sickle cell traits, and this is an affected child. In this affected child, there is homozygous inheritance of sickle cell traits from both the father and the mother. For those who have the sickle cell traits, there is just an heterozygous inheritance of the traits. So it's a probability, 1 in 4 chance of a child being affected with sickle cell disease when both parents are carriers of sickle cell traits. Now to the pathophysiology of sickle cell disease. Hemoglobin S arises from a single point mutation of the DNA. In this case, thymine is substituted for adenine in the cis codon of the beta chain of hemoglobin. This causes coding of valine instead of glutamic acid as position 6 of the beta globin chain. It results in sickled hemoglobin with the different physical properties and the problem with solubility. These abnormal cells are also at increased risk of lysis, hence they have shorter lifespan. Whereas in hemoglobin C, lysine replaces glutamic acid at the position 6 of the beta globin chain. This is a pictorial representation of the pathophysiology of sickle cell disease. In this instance, the blood cells are normal and they are able to meander freely within the blood vessel. But in cases with sickle cell, you can see the abnormal shape of the cells and difficulty in the cells in navigating through the narrow blood vessels. Hence, they obstruct narrow blood vessels, causing hypoxia, stasis, and subsequent pain. The substitution of this hydrophilic amino acid with the hydrophobic one is the root cause of the disease in sickle cell anemia. Sickled hemoglobin polymerizes when it is deoxygenated, leading to a cascade of reactions and injury to red cell membrane, causing increased hemolysis and multiple organ dysfunctions. Low oxygen tension causes the blood cells to become sickled. Although this is a reversible reaction, but it causes occlusion of tiny blood vessels, causing distal hypoxia and subsequent pain. Sickling is as a result of increased blood viscosity, leading to stasis and subsequent obstruction and infarction. There is marked inter-individual variability in the expression of sickle cell disease. It is possible to see patients with sickle cell disease with less frequent crises, while some others are predisposed to frequent sickle cell crisis and hemolytic crisis. Both genetic and environmental factors have been known to be responsible for this. Known genetic factors that contribute to disease severity include the pattern of sickle cell inheritance, the nature of fetal hemoglobin. When fetal hemoglobin is high, there is less risk or less frequency of sickle cell crisis. But in situations where fetal hemoglobin is low, the patient is at increased risk of crisis. It is known that fetal hemoglobin has higher affinity to oxygen and hence reduces the painful crisis in patients with sickle cell disease. Other modulators of expressibility of sickle cell disease include environmental factor, the access to optimal health care, the ambient living condition or environment, and availability of finance to take care of affected individuals. These are the precipitants of sickle cell crisis. The first of them is infection and infestation. The common infection in pregnancy includes chest infection and urinary tract infection. Hence, patients with these infections who are also sickle cell disease patients should be treated promptly, as it may be a cause of crisis in them. Infestation in terms of malaria is also another cause of repeated crisis in patients with sickle cell disease. And sickle cell disease patients who present to the hospital with symptoms suggestive of malaria should be investigated and treated promptly before it leads to crisis in them. Low oxygen tension is also another risk factor for sickle cell crisis. Dehydration is another common cause of sickle cell crisis. Dehydration may be common in pregnancy, especially in cases of hyperemesis gravidarum, or when there is nausea in early pregnancy in which the pregnant woman does not wish to take anything orally. In this case, she's at increased risk of having hemolytic crisis or painful bone crisis, and as such, Such patients should be admitted and rehydrated and counseled on the importance of hydration. Acidosis, which may result from excessive vomiting, is also a precipitant of sickle cell crisis, and these are things that are common in the early part of pregnancy, especially in the first trimester. Hence, care should be taken to avoid these precipitant factors. Concomitant medical condition may predispose a patient with sickle cell disease to having painful crisis. These concomitant conditions include patients with hypertension, diabetes, or asthma coexisting with sickle cell disease. Extreme physical exercise is another predisposing factor. Hence, as much as possible, patients with sickle cell disease should be told to avoid extreme or physical exertion, as it may be a cause of predisposition to sickle cell crisis. Extremes of temperature, such as extremely cold weather or hot weather, may precipitate crisis in these patients. Also, the ingestion of alcohol is the precipitant of sickle cell crisis, and pregnancy, which is exactly what we are discussing, is another risk factor for increased frequency of sickle cell crisis. Now to the effect of sickle cell disease on pregnancy. The effect of sickle cell disease on pregnancy may be maternal or fetal. Maternal complications include anemia. As said earlier, patients with sickle cell disease are at increased risk of hemolysis. Hence, they are predisposed to having anemia in pregnancy. Also, the infection in these patients is another complication which may be seen in mothers with sickle cell disease. Pseudotoxemia of pregnancy may also occur in pregnancy, and this may complicate sickle cell disease. Chronic blood transfusion, which may be increased in pregnancy, it's another known effect of sickle cell disease on pregnancy. Also, during pregnancy, patients with sickle cell disease may have increased incidence of crisis. They are at risk of preterm labor, bone marrow embolism, and even maternal mortality. Other things that may complicate sickle cell disease in pregnancy include cerebrovascular accidents. Antenatal hospitalization may be increased in patients with sickle cell disease as compared to normal patients. Also, these patients are at increased risk of having operative delivery, especially delivery by cesarean section. They are at risk of antepartum hemorrhage as a result of placenta abruptio because of defective placentation in patients with sickle cell disease. Also, this patient with sickle cell disease end up spending more in the hospital or during pregnancy, hence increased costs in management of pregnancy in these patients. Now to the fetal complications. There is increased risk of early pregnancy losses in patients with sickle cell disease. They may suffer intrauterine growth restriction because of defective placentation, and this may lead to intrauterine fetal demise. Also, they are at risk of preterm labor and prematurity with its attendant complication, which include increased perinatal loss. Now, the effect of pregnancy on sickle cell disease. This includes increased risk of thrombosis, increased severity of crisis, which occurs in pregnancy, increased frequency of crisis. So the severity, crisis increases in severity, it also increases in frequency in patients with sickle cell disease. They have more severe anemia as compared to when they were not pregnant because of increased hemolysis in them. Also, the need for blood transfusion is noted to be on the higher side in patients who have sickle cell disease when they are pregnant. There are reasons why one may want to transfuse patients with sickle cell disease during pregnancies, and these indications are well spelled out. All cases of sickle cell disease crisis with hemoglobin below 8 grams per dl should be transfused. Also, all cases with hemoglobin less than 8 grams per dl at 36 weeks gestational age or more should be transfused. This is because more blood will be lost at delivery of the fetus, hence this patient will be at increased risk of crisis. This is why they need to be optimized from 36 weeks and above when their hemoglobin level is found to be 8 grams per dl. All cases with hemoglobin at level of 7 grams per dl at any gestational age should be transfused. So packed cell volume below 21%, which is equivalent to 7 grams per dl, is an indication to transfuse patients with sickle cell disease, irrespective of the gestational age of such patients. And also, where clinical judgment indicates the need for blood transfusion, transfusion should not be withheld from patients with sickle cell disease. And when transfusion is to be given to these patients, one must ensure that hemoglobin AA blood is given to such patients. The indications for blood transfusion also include crisis, infection of any form. Patients who present with eclampsia may need to be admitted, and other complications in pregnancy. So when you see patients with sickle cell disease and they come with crisis, infection, eclampsia, or other pregnancy complications, it is an indication to admit such patients. They should be managed within the hospital and not on outpatient basis. Now to preconceptional care. It is known that preconceptional care improves the outcome of pregnancy in women. But in patients with sickle cell disease, the pregnancy outcome is much more improved when they undergo preconceptional counseling and care. Patients with sickle cell disease should be counseled about sickle cell disease, its effects on pregnancy, and the effect of pregnancy on the severity of sickle cell disease. Also, they should be taught on how to avoid crisis, that is the precipitant of crisis, which include the extreme of temperature, dehydration, physical overexertion, which may lead to increased crisis in them. For patients who have not been vaccinated against encapsulated organisms, the preconceptional period is the best opportunity to vaccinate these patients before they become pregnant. Preconceptional care should be emphasized in patients with sickle cell disease, as it is known to improve both maternal and fetal outcome. Then preconceptional care also enables the optimization of this patient prior to pregnancy and helps to screen for end organ damage, which could have resulted from chronic hemolysis and hypoxia. Chronic complications which may complicate sickle cell disease should be sought for during the preconceptional period. And this includes pulmonary hypertension, which is assessed using echocardiography. Renal and liver function tests of these patients should be assessed and optimized prior to pregnancy. Retinal screening should be done in patients with sickle cell disease as they are known to be at increased risk of retinal damage. This is especially of importance in patients with hemoglobin SC, as they are at greater risk of having retinopathy from sickle cell disease. Screening for iron overload and aggressive iron chelation may be needed in patients with sickle cell disease, as we know that repeated hemolysis predisposes them to having overload of iron. Also, partner screening and genetic counseling can be offered in the preconceptional period, where the partner is found to be a carrier of sickle cell traits. Adequate counseling must be offered, including prenatal diagnosis and termination of pregnancy, should there be a need for such. Vaccination must be optimized and ensured prior to pregnancy. Preconceptional folic acid, that is 5 mg of folic acid, should be given once daily preconceptionally and throughout pregnancy in patients with sickle cell disease. Medications of patients with sickle cell disease must be reviewed before pregnancy. Some of these patients will have been on hydroxyurea to limit the frequency of crisis in them because of its effect on the membrane. Hydroxyurea must be stopped at least 3 months prior to conception to prevent teratogenicity in patients with sickle cell disease. Those of them who are on angiotensin converting enzyme inhibitors and angiotensin receptor blockers must be switched to other antihypertensive agents, as this may result in fetal anomaly. Now to making a diagnosis of sickle cell disease in pregnancy. Some patients present at the antenatal clinic with sickle cell disease without prior diagnosis, and such patients must be identified and managed as patients with sickle cell disease. History is important in such patients. History of recurrent bone pain during childhood, history of hand-foot syndrome, history of jaundice, chronic jaundice may be a pointer to sickle cell disease in this patient. The family history of sickle cell disease, in which case one or more of the siblings may be affected, should also be sought in these patients. Clinical examination in this patient may reveal short stature, unsteady gait from avascular necrosis of the head of femur. Also, the patient may be pale and they may be jaundiced. Sickling test should be carried out. The hemoglobin level of this patient should be assessed. The reticulocyte count may also be a pointer to sickle cell disease, as they are at increased risk of having reticulocytosis. Hemoglobin electrophoresis is also important in making diagnosis of sickle cell disease in pregnancy. Now to the antenatal care of patients with sickle cell disease. This must involve multidisciplinary action, and doctors with experience in high-risk antenatal care must be involved in management of patients with sickle cell disease. They must be screened for end organ damage if it has not been done preconceptionally. They must avoid precipitates of crisis. Then influenza vaccine must be recommended if it has not been given within the previous year during the antenatal period. To ultrasound schedule in sickle cell disease patients. Women with sickle cell disease patients should be offered a viability scan between 7 to 9 weeks of gestation. Routine first trimester ultrasound can be done within 11 to 14 weeks for dating. Also, anomaly scan must be done at 20 weeks of gestation because of increased risk of congenital anomalies in some of these patients. Serial fetal biometry scan is important in patients with sickle cell disease. This must be done every 4 weeks after gestational age of 24 weeks. Antenatal diagnosis may be offered in cases where both parents are affected, that is, in which case the mother is a sickle cell disease patient and the father is a carrier, or both are even sickle cell disease patients. Fetal DNA analysis can be carried out using the amniotic fluid. Chorionic villus sampling can be done, and hematopoietic stem cell transplants can be offered in vitro where the fetus is affected. And in some instances, abortion may be offered when the fetus is found to be affected. Now to complications of sickle cell in pregnancy. Let's take a look at acute painful crisis. Bone pain crisis is the most common complication in sickle cell disease. The pain results from activation of nerve endings in the ischemic bones. As said earlier during the pathophysiology, there is obstruction to blood flow in sickle cell disease, leading to hypoxia and subsequent ischemia and pain. The commonly affected bones are the long bones, which include the femur, the humerus, the vertebra, the pelvic bones, the rib, and the sternum. Optimal management of painful crisis is important in patients with sickle cell disease. This painful crisis is very common in the last 4 weeks of pregnancy. It may also be common in some during labor and in the first 4 days of delivery. Rapid assessment and multidisciplinary management is important in these patients. Analgesia must be given generously. Petidine must be avoided in patients with sickle cell disease because of the predisposition to seizures. Non-steroidal anti-inflammatory drugs should be used only between 12 and 28 weeks of gestation. That is, in the early part of first trimester, it should be avoided. Then later in pregnancy, it should also be avoided because of the risk of patent ductus arteriosus. The need for oxygen and fluid must be quickly assessed in patients who present with crisis. Prophylactic heparinization with subcutaneous heparin may be needed in these patients. Mild pain may be managed with rest, oral fluid, and paracetamol, or with the addition of weak opioids. Management of patients must, however, be individualized. The World Health Organization analgesic ladder should be followed in the management of patients with painful crisis in pregnancy. Paracetamol can be given for mild pain. Non-steroidal anti-inflammatory drug can be used for mild to moderate pain between 12 and 28 weeks of pregnancy, while weak opioids can be used for moderate pain and stronger opioids such as morphine for severe cases. However, in all cases of painful crisis, analgesia must be given. Acute chest syndrome. This is another painful complication of sickle cell disease. In most instances, it presents typically as pneumonia. It is common in patients with sickle cell disease, and it is seen in about 7 to 20% of such patients. The characteristics of acute chest syndrome include tachypnea, chest pain, cough, shortness of breath, and the presence of new infiltrate on chest X-ray. Early recognition of acute chest syndrome is important in patients with sickle cell disease. Like I said earlier, the features are so similar to that of pneumonia and must be one of the differential when patient presents with chest pain. Treatment is with intravenous antibiotics, oxygen, blood transfusion where there is need, as in non-pregnant women. These are the investigations that are carried out when patient with sickle cell disease presents with painful crisis. Full blood count with differentials must be done. Blood film must be assayed for malaria parasites. Urine sample must be taken for microscopic culture and sensitivity. Blood culture must be done to rule out infection. The liver function test has to be done, and electrolyte urea and creatinine should be assessed. Pseudotoxemia of pregnancy is another complication seen in patients with sickle cell disease. This is associated with severe bone pain. It may occur near term, in labor, or in early puerperium. They present with systolic hypertension and proteinuria. This is an indicator of imminent bone marrow embolism, and patients must be delivered immediately. Acute sequestration crisis. This may present as increased in liver span and splenic span in few instances. But most patients with sickle cell disease will have suffered splenic infarction earlier in life, but few still present with splenomegaly. It may occur near term, in labor, or in early puerperium. Transfusion with Park cell is the mainstay of treatment in sequestration crisis. Blood sample must be taken frequently in these patients, and Park cell volume must be checked frequently to assess for need for further blood transfusion or worsening symptoms. Other modalities of management is as listed earlier for sickle cell crisis. Now to the intrapartum care of patients with sickle cell disease. For patients who successively carry pregnancy to term, elective births through induction of labor or by elective cesarean section must be carried out at 38 weeks of pregnancy. Delivery must be taken in an hospital with facilities for management of high-risk mothers and babies. Sickle cell disease is not a contraindication to attempting vaginal delivery or vaginal birth after cesarean section. Suitable positions for delivery must be adopted by patients who have had hip replacements. The relevant multidisciplinary team should be informed as soon as labor is confirmed in patients with sickle cell disease. Women should be kept warm and given adequate fluid during labor. Continuous intrapartum electronic fetal heart rate monitoring is recommended owing to the increased risk of fetal distress, which may necessitate operative delivery in sickle cell disease patients. Regional analgesia is recommended for cesarean section, and in labor, epidural analgesia is the best for patients with sickle cell disease. Postpartum care of patients with sickle cell disease involves a frequent assay of capillary sample for packed cell volume, as this patient has at increased risk of having crisis even in the puerperium. Maternal oxygen saturation must be maintained above 94%, and adequate hydration must be ensured until patient is discharged from the hospital. Heparinization with subcutaneous heparin must be ensured in the first 7 days post-delivery, following vaginal delivery, or within the first 6 weeks for patients who have had cesarean section. Antithrombotic stockings must be recommended in the puerperium for patients with sickle cell disease. For those who undergo labor among patients with sickle cell disease, the labor must be monitored closely with pathograph. Prophylactic antibiotics must be given to them. Intermittent oxygen must be supplied to these patients. Blood must be grouped and cross-matched, and transfusion must be ensured when there is need for such. Adequate analgesia, as said earlier, must be ensured. Prolonged labor must be avoided in patients with sickle cell disease. Packed cell volume must be monitored 4 hourly when they are in labor. And for those with operative delivery, regional analgesia is preferred. But in cases where general analgesia has to be employed, adequate oxygenation must be ensured in such patients. The second stage of labor must be shortened in patients who have sickle cell disease, and vaginal examination in such patients must be minimized. In the puerperium, patients with sickle cell disease are not without complications, hence the need for packed cell volume check. The vital signs must be monitored frequently. Antibiotics and folic acid must be continued, and patients should be kept in the hospital for about 5 to 7 days before they are discharged. They must be reviewed every 2 weeks within the puerperium, and they must be told to present in the hospital in case of any symptoms. They must be counseled on contraception and the need to limit family size. Now to prevention of sickle cell disease. This may be primary or secondary prevention. The public has to be enlightened on sickle cell disease, its effects on pregnancy, and how to avoid sickle cell disease as a whole. That is premarital screening for genotype. Genetic counseling for intending couples must be ensured by all organizations. Pre-implantation diagnosis can also be done for patients who undergo assisted reproduction. Prenatal diagnosis using chorionic villus sampling or amniocentesis can be done in patients with sickle cell disease. For those who have this disease and now present in pregnancy, early diagnosis and optimal care is important, and adequate nutrition must be ensured. In summary, sickle cell disease is the commonest haemoglibinopathy in sub-Saharan Africa. Maternal and perinatal mortality and morbidity is high when pregnant women with this disorder are not adequately managed. Adequate history and investigation will aid its diagnosis. Management of sickle cell disease is multidisciplinary. Adequate knowledge of disease pathophysiology will improve patient outcome. These are my references. Thank you for listening.